Just is on live ಒಂದ್ಸರಿ ಯೂಟ್ಯೂಬ್ ಚೆಕ್ ಮಾಡ್ತೀನಿ. ಹಲೋ, ಸ್ವಾಮಿ ಮಾತಾಡಿ ಒಂದ್ಸರಿ.
Hello, can you hear me?
Yeah, just I'm checking on the YouTube.
Hello. Good morning and good afternoon, everybody. Welcome to our Gina online teaching platform. I would like to heartily welcome our guest lecturer, Lydia. Welcome SSMS team. At last you made it. So I'd like to welcome Lydia Sharan. Lydia is originally from Dharwad. She's completed her MSc in 2009. No, she qualified as a bachelor in 2009 and then she pursued her master's from SDM Dharwad. Currently, she's working in St. James Hospital, Dublin for the last 4 years. So she's currently working as a tracheostomy nurse specialist for the last year or so.
Yes.
So it's all yours, Lydia.
Thank you, sir. Thank you. Good morning, everyone, and good afternoon. So happy to see students and faculty who have taken time to join this platform. Sir has very kindly introduced me. I know Sir Swami sir for the last 5 years. And thank you, sir, for giving me this opportunity, and Gina for providing this platform. So the topic that I will be talking is on tracheostomies and laryngectomies. As a student, I remember I was very scared of a tracheostomy. I hardly saw a tracheostomy in ICU setting, and the first time I was there, I was very scared, and I said, let the senior nurse handle a tracheostomy patient. So anything to do with airways is challenging. But I have been working here in St. James's Hospital here in Dublin for the last 4 years. I worked on an ENT ward which had purely tracheostomies, and I was shocked to see the number of patients having tracheostomy. So I kind of developed interest, and I have working as a specialist in that. So today, the terms and the conditions that I will be telling, we may not be very familiar, but it's a good opportunity to just get to learn more about it. Okay. So there will be some things that you may hear it for the first time. So at the question and answer session, you can ask me, and then we will have quite an interactive session after that. Okay. So to start off with, I will be doing my screen share so you can see the slides. Sorry for that. Yes. So this little lovely necklace that you see around the neck, okay? So there is a lot going on behind it, okay? So we will see what it is all about. Okay, so when you speak about tracheostomy, so as you know, it's an opening which is made in the neck. So going through the anatomy, you already know all this, but I will briefly tell you our airway respiratory system. You have your nasal passage, that is your nose. Okay, so you have your nasal passage, then you have your throat, which is your pharynx, and then just below the pharynx you have something called as your voice box, which is called a larynx. Okay, below that is your trachea. So trachea is otherwise called as the windpipe. Okay, and so tracheostomy is basically an opening which is made in the trachea. Okay, in the cartilaginous rings, trachea has these little rings you can see. So usually an opening is made between the second and the fourth ring. Okay, just behind the trachea is your esophagus. That is where your food goes through in. Okay, so I won't be spending much time on this because you know it. If it's a surgical tracheostomy, you can see it is done in theaters. What they do is the surgeon does a surgical incision, and he opens the area here in front of the neck and makes a hole in the trachea and puts in the tube. So we will see all that. So clear with tracheostomy. You can use your chat box if you have any questions. I think they can do that, isn't it, sir?
That's right. Yeah, yeah.
Yes,
Sorry.
yes.
So thanks for reminding. Yes.
Yes, you
Type,
can use
type
your
in your
chat.
questions and type in your questions in the chat box. And those guys who are watching on the YouTube, please do type in your questions. We will answer your queries at the end of the session. Thank you.
Okay. And if I ask you something, maybe you can give me a thumbs up or something like that, just for me to know that you're able to get what I'm saying. Okay.
Sure.
So we try and make it interactive. Okay. So what is the need for a tracheostomy? Why should someone have a tracheostomy? Not all patients would have a tracheostomy. So there are many reasons, but I will just briefly tell you what could be the probable reasons. So if there is any, the first and the foremost thing is if there is any obstruction in the upper airway. It could be an infection, it could be any kind of tumors. Okay, so sometimes we just get patients with stridor. They would have just come in, they are totally out of breath, they are at home and they just cannot breathe and they are making different noises and they are struggling for breath. They would come into the ward, they would come into A&E, and on assessment you will know that there is a tumor which the patient doesn't know that there is a tumor that was growing which was causing obstruction. So it could be a tumor, it could be anything, and usually in ENT and max packs, if there are tumors in the neck, so what we normally do is they do a tracheostomy for patients so that it reduces the post operative swelling. So in order to recover in their post operative phase, patients have tracheostomy. So once the swelling is gone, they are recovered, then the tracheostomy is closed. So it could be different reasons. So now we all know the famous COVID. Okay, so this is a big problem here. So in ICUs, if patients are on ventilators, so usually after say 11 to 14 days, they cannot have the ET tube in place for so many days. So you have to switch if they're still oxygen dependent. Okay, so there needs to be a other way. So intensivists or ICU specialists opt for putting in a tracheostomy tube so that even if they are off ventilator, they are able to still clear secretion. So this I think you are familiar with. Some patients are not able to be, they cannot be extubated easily. Okay, so every time you extubate, within few hours, again they go back on ventilator. So you cannot keep putting the ET tube back in again and again. So if there is a failure to extubate, then they would opt for doing a tracheostomy. Okay, then there are other problems as well. So if patients are having difficulty in clearing their secretions, okay, chronic respiratory failure, or even patients with burns. Some of you would know that if a patient comes in with burns, so the only way, because in burns there is swelling and there can be closure of the respiratory tract. So in order for that, they would use a surgical tracheostomy to aid in the clearing of secretions. And then these are rare conditions. Okay, if a patient has a stroke or a bilateral vocal cord palsy. So that's when a tracheostomy can be done. Okay, so there are different reasons and indications for which we do that. So coming next to the types of tracheostomy, they can be classified. Okay, they can be temporary. For example, if some patient is coming for a neck dissection, okay, some lump found in the neck, so they come in for surgery. So just for the period of the surgery, they would have a tracheostomy. Once the neck is healed, as I told, they the tracheostomy is removed and the stoma is closed. So it be for temporary reasons. Okay. And then they can be for long term or permanent. So here I have seen that some patients go home with tracheostomy and they have to care for themselves at home because if they are not able to clear their own secretions, if the tumor is not operable, that means there are some kind of tumors you cannot operate, some kind of cancers that cannot be operated. So those patients end up with permanent tracheostomy, or some patients who are end of life care. Okay, so those patients we would not be doing any kind of surgery or anything like that. So we send them home with a tracheostomy. Okay, so again they can be divided as elective, that is planned. Patients have booked their operations, so they come in. And then otherwise you can have an emergency tracheostomy where they are not aware of what is happening, their breathing pattern changes, and they are just rushed to the hospital, and then they come to know that they have some kind of tumor, which is a shock for patients. Okay, so we come across different types of patients who would end up with a tracheostomy. So again, there are different methods of inserting a tracheostomy. So if it is mm, uh, an emergency and an elective, it could be a surgical tracheostomy, which I will tell you, and percutaneous. The second type is percutaneous. So what happens in a surgical? So surgical here, as you see, surgical tracheostomy is done by either ENT or max fax team or cardiovascular team. So these patients are taken to the operating theater, and there they have the surgical incision. Okay, so I won't be telling you more about it, but as we go further, we will explain. Okay, so as I told you, it's a surgical incision between the second and the third, or the third and the fourth. That is ideal. So there are different um, techniques of incisions. Some people just like to make a square window. Some people like to have a longitudinal view. So it depends on the surgeon. However, whatever is the type of the thing of the incision, it is all documented so that we know what kind of incision the patient has had. Okay, so just for you to remember, you don't need to know much about this. There's only two types: surgical and percutaneous. Percutaneous is a bedside procedure. Okay, usually if anyone has worked in ICU, you will know this. So usually what happens, the intensivist or the ICU consultant, they come in and they just do this procedure bedside. They ask the nurse, how many days has the patient been ventilated or intubated? If they say 11, 12 days, then they'll be like, okay, get me the trachea tray. I will do a procedure. So it's a bedside procedure. Okay, so it is this is the kind of tube that they use. It's called a dilator, and they do it at the bedside. Okay. So, as a nurse, what you need to know, we will be concentrating on that. So, if it is a surgical tracheostomy, when the hole is formed, it takes about 3 days. Okay, roughly about 3 days for the hole to form. Okay, but if it is a percutaneous tracheostomy, it takes about 7 days. Okay, 7 to 10 days for the hole to be properly formed. So, what does it mean? Why, you must be asking me, why are you telling me this? It just means before the third or the fourth day in the early week, it's difficult to put the tube back in. Okay, so if the tube will the skin will just close quickly and you will not be able to put the tube back in. So that is why it is very important to know whether it is a surgical or a percutaneous. If it is a surgical, after 3 days the stoma is well formed. Okay, so now coming to what is this tracheostomy? I'm going on telling you from that time. So what is it exactly? So we'll just quickly see what are the parts of a tracheostomy tube. So I have with me a sample. So I'll show you. Can you all see it? Maybe give me a thumbs up if you can see it.
Yes, we can.
Yes, okay, very good. So this is a tracheostomy tube, and I work with these tubes all the time. Okay, so what does it mean? So the parts of the tube. So it's a double lumen tube. That means there are two holes, two lumen. So you can see this. So you have the outer ring. This is the outer ring, and this is the inner cannula. Okay, so it's a double lumen tube. Okay, these things, can you see these two things? It's called a flange. I'll just mark it and show you here as well. These things is called a flange. So I will be referring to these things in the next few slides. That's why I'm just telling you what these mean. Okay, so this is the cuff. Can you see this balloon-like thing? It's called the cuff. So and this is called the pilot, the blue thing. Okay, the blue thing, it's called the pilot. So on this pilot, usually the number of the size of the tube is written. Okay, it's written on this, and it is also written on the flange. So I can just look at it and say what size the tube is because it is written on this. This particular tube has an additional feature called as a subglottic port. Okay, so in simple to explain, when the tube is in the neck, okay, and if the balloon is up, okay, it is called a cuffed tube. Cuff inflated. Okay, inflation means air is inside. If I take off the air, okay, if I just use a syringe and take off the air, okay, this cuff is deflated. Okay, this cuff is deflated. So what does it mean? It just means that you can classify these tubes based on cuff inflation and cuff deflation, and there are other, I will show you, uncuffed tubes and cuffed tubes. So the main use of these cuffed tube is, you know, when the tube, see, nothing nice comes out of these tubes when you suction. Okay, there is a lot of secretion which is sitting inside the lungs, and there is some secretion sitting outside the lungs. So when the cuff is inflated, you can use this port to suction. Okay, to suction, and whatever material or whatever mucus or whatever is sitting above this cuff, you can take out the, using a syringe, you can be able to draw it. Okay, so this is the subglottic port. Okay, so you just use this syringe and you can draw out the secretions. Okay, I'll tell you why. So this is basically a tracheotube. So can you just give me a thumbs up if you all have understood what it is?
Well, I
Yeah. Yes. Okay, cool. Okay, so this is basically how it looks. Okay, so one more thing what you need to know is called as an obturator. Okay, obturator, this is like a guide wire. So what happens when we are putting in the tube, this usually just helps to guide to go in. Okay, so what we do is we just, it comes in pre-packed like this. Okay, so you just lubricate, you put the tube in, and then you have to immediately take it out. So this is like a little guide wire, so obturator. So why why I'm telling you all this is you need to know the parts and also to have them at the bedside if the tube falls out. Okay, so coming back to the different types of tubes, as I showed you, cuffed cuffed tube, you can see the balloon is inflated. Okay, if non-cuffed tube is, it's a plain clear tube. Can you see? There is no cuff at all. Okay, you cannot see anything. It's just plain simple tube. Okay, so that is one way of classification. The second way of classification is fenestrated, non-fenestrated. Fenestrated means, can you see the difference? There are tiny windows or holes. Okay, so here can you see?
Yeah.
There are just tiny holes or windows. Okay, so these are called as fenestration. So even this is called an inner cannula. Even the inner cannula will have tiny fenestrations, which means when the patient is able to speak, obviously when the patient has a cuffed tube, there is no air that can come out through the mouth, so he cannot be able to speak. But when he's using or when she's using a fenestrated tube, that is a tube with the little holes, that means air is coming out and it is passing through the vocal cords, and the patient is able to speak. Okay, and then again you have cuffed non-fenestrated. So there are different types. So we will decide according to the patient's status what kind of tube to use. Okay, so these are normal tubes. So what are the factors that influence the tube choice? Can I put in any kind of tube for any kind of patient? No, there is some guidelines that I need to follow, or the surgeon will tell us what kind of tube the patient will need. Okay, so first, if the patient is in ICU, for example, now you think patient is in ICU and you know I won't, and the patient will need oxygen. That is why he's in ICU and he's ventilated. Okay, so for that kind of patient, you will need a cuffed tube. I showed you that? It's a cuffed tube, a balloon which is inflated, so that all the oxygen from the ventilator is going into the patient and there is no escape. Okay, so you need a cuffed tube. So the problem now is this cuffed tube, you can't just leave it in like that. You need to keep checking something called as the cuff pressure. Okay, so you see this tiny instrument here. Has anyone seen it before?
We can't see it, India.
Okay.
Sorry, 1 second.
This instrument?
Yes, we can. Yeah.
Yeah. So
Yeah.
this is called as a cuff pressure manometer. Okay. So it's again on my slide. You can see.
Yes.
Can you see? So, so what is the reason that you need to check your cuff pressure? It is quite self-explanatory. So you know about pressure ulcers. You have been learning about it. So pressure ulcers can happen even inside. Okay. So imagine this balloon which is inflated like this, overinflated. Okay, it is putting pressure on the trachea. Yeah, and you know it's all very soft inside. So sometimes patients can develop pressure ulcers. Okay, or any kind of like more complications like tracheomalacia or anything like that, if the patient, if we are not checking the cuff pressure. Can you see this?
Yes.
Yeah, so it's very important that we maintain a normal pressure. Okay, so so this instrument, it is only come out now. It wasn't there before. Okay, so here it just, what you do is you just use this cuff pressure manometer at the end of the pilot and you put it this way. It will tell you, it has a needle. Okay, it has a needle. It will tell you in which range it should be. So there is a green range. Okay, there is a green range. Usually the needle should be inside that. Okay, if it is more than that, if the pressure, now it is showing 60. Usually the pressure is between 25 to 32 centimeters of water, because that is the usual capillary pressure inside our trachea. Okay, so if it is 60, it is obviously overinflated. So we just use, there's a little red button, we remove the air from there, and we just, and now the needle is back into um, the green range. Okay, so you might say, I don't have this instrument, so how will I do? Okay, so usually what we do, when we just put in 5 to 7 ml of air into this. Okay, so that's the simple method. Just make sure that you have 5 to 7 ml of air, which is pushed into it, which equals to the pressure that you need. So this helps in preventing pressure ulcers, the right cuff pressure. Okay, if it is lower, okay, if the cuff pressure is too less, now what you think will happen? If the cuff pressure is too less, you check on your assessment, you see that it's completely deflated. What would happen? The answer is there. So it just means that the patient is risk of aspirating, so it does not serve any purpose. So whatever secretion is sitting above this cuff, it's silently leaking into the lungs. Okay, it can be feed, it can be your food, ng feed, anything. It can silently, if the patient is aspirating, it can silently go into the lungs, so it is not doing any harm. So that's a little bit of cuffed tracheostomy tube. Okay, then as I already told, if the patient is good, he has recovered better, and you can switch him to a fenestrated tube, which will help in speaking. And some patients who have some abnormality in the neck, okay, so we are using very big, huge tracheotubes. They can be little scary, okay, but they have markings here, so it just tells you. So it's different types of tubes. You don't need to be bothered about all that. So you just know cuffed tube, non-cuffed tube, fenestrated, non-fenestrated. Is that clear? Okay. So what do you need to know as a nurse? Okay, as a nursing student, what if you are given a patient with a tracheostomy? What do you need to know? You need to know your local policies. Okay, what is your local policy? What is it saying? Okay, and you should ask yourself these questions. Why does the patient have a tracheostomy? Like, so then you go back to the indications. Okay, he had, for example, okay, he had a road traffic accident, that is why he has a tracheostomy. So you need to know these things. Why, when was it put in? Was it surgical or percutaneous? When was it put in? Because if you know this, you know, even if the tube falls out, you need not worry if it is more than 7 to 10 days. Okay, if it is less than 2 days, he has just come from theater and the tube fell out, will you just be calm? No, you have to, it's an emergency. So it's very important that you know when. Okay, and was it surgical, and the size and the type. Okay, so it's self-explanatory, so that you have the right size of tube when the tube falls out. Okay, so later on, as you do your physical assessment, you will also check for how the patient is coughing, whether he's able to swallow. So here we have something called as speech and language therapist. Okay, so they kind of just assess for swallowing and all that. So we liaise with them often. And then your main work as a nursing student or as a nurse is to check the inner cannula. Okay, so this is the inner cannula. So every 4 hours, you need to check the inner cannula, so that sometimes the secretions get caught up in this and it blocks the tube. So that is why you need to keep checking the inner cannula. So it's not that if the tube is blocked, you take out the tube. No, that is why we have a double lumen tube. Okay, so the emergency bedside equipment. So this is one of the things that is very important. So we call this a trachea tray. So what happens is, if we get to know that we are getting a patient from ICU or from anywhere, that a patient has a trachea in place, we set up the room. So when you set up the room, so you need to make sure that the patient has oxygen, humidification, and the suctioning equipment. Okay, so ensure that you have the correct size suction catheters. So if you have seen, this is a suction catheter. Are you familiar with this?
Yeah.
Yeah. So suction catheters, suction machine, and we just have introduced something called as a trachea tray. So it has spare tubes basically. Okay, it just has a spare tubes, and we have something called as a trachedilator. I will show you what is the use of it. It's a trachedilator. That means when the tube falls out, you keep the stoma opened. Okay, and then there are few other things that are there in the trachea tray. So as a nurse, if or as a nursing student, if they tell you, oh, we are getting a patient, you should be able to set up the room to receive the patient. Okay, then as usual, then you need sterile inner cannula. So you get a box of disposable inner cannulas, and then you need water for suction or saline for suction. So this is all according to your local policy. Okay. So now you have a patient who's there for say 2 3 days, and you're every day you're posted to the same patient. So what will you be checking? So you will, as if you have a patient with a tracheostomy, it's important that you check the site. Okay, you make sure that the site is clean. Okay, you make sure that the site is clean, because you see there are, as I have told you, that there are pressure sores inside. There can be pressure sores just under the skin here. Okay, so this is called the flange, as I told you. So the flange is putting pressure on the neck. So if you do not inspect the site and see, there can be a pressure sore, and there have been like grade 2, grade 3, very, very bad pressure sores if patient is not checked. So you clean you just clean it as sterile as you can using normal saline. So you put, according to your local policy, you can put Vaseline to just keep it nice and moist. Okay, so and check for signs of bleeding. So usually we just put a thin dressing just below the flange here. Okay, this is the flange. We just put a thin dressing below the flange. Sometimes some patients are come with uh, the flange sutured in, and they have, you can see, can you see this black thread here?
Yes.
Stay suture, do not remove. So usually surgical patients have this thing called as stay suture. That means when the surgeon is operating, he'll just put that stitch. So if the tube accidentally falls out, you pull the stay suture into opposite. You just pull it this way. So when you pull it into opposite direction, the hole is, you can see it collapses. Once the tube falls out, it collapses. But if you pull it, you can keep the hole open and the tube can go in again. Okay, so it's a stay suture, so we keep that in at least for 10 days. Okay, now coming to the ties. Okay, so there are different kinds of ties that you tie it with. Have you seen patients with ties? Yes?
Yeah. Yes.
Yes. So it's called as cotton ties. This is what we normally use anywhere. So one thing is, I won't show you how to tie it because you know, but don't be making nice pretty bow like this. Okay, don't just make a nice bow which looks nice. It doesn't help. The patient will pull it out and take out the tube and run. So don't do that. Make a tight knot, at least 2 3 knots. Okay, that is what you need to do. And don't make it too tight so that the patient will have again a pressure ulcer, because it's a very delicate area. So So you see here how the patient, you need to have at least one finger space, okay, just to make sure that it is not too tight and restricting. So we are using Velcro ties here, okay. So it's just using Velcro ties. So there are two different ties, okay, and it's a soft part and the little rough part. The soft part goes onto the skin of the patient, and then you just put this. So these kind of things you can use for patients who can understand and who know things, not for a confused or an agitated patient. He will just pull out the tube and off he will go. So this is one more thing that you need to check. So as you are checking your daily assessment, just make sure if the ties are too dirty, please don't leave it on. Change them, and you can change them at least once a week. Okay. So as you know, the next thing is humidification. You know, for us, normal, you and me, we have cilia in our nose, which will help to humidify our air. That means the room temperature is different and the temperature in our body is different. So we want the air to be humidified. So, but in case of a patient with tracheostomy, he does not have this option because this part is bypassed. His airway is starting from the neck. So he does not, cilia don't have any role to play in this thing. So we have to artificially humidify. So there are different things that are available. So it's important to know what kind of humidification fits the patient. Okay, sometimes if you just give plain oxygen, it can just it can dry out. Okay, it can dry out the secretions and the patient will be in more trouble. So in order to get oxygen which is humidified, here we use something called heated humidification. It's called an air vogue. Okay, it they set it up at a different temperature, and you can give up to 15 liters of oxygen through this machine. So this part of the thing, it fixes onto the trachea tube, and the patient gets oxygen. There are some things called as this heated humidification is recommended for patients who just come in from theater. Okay, so who are still oxygen dependent, we would give that, and he's still not mobile. But once the patient is mobile, he wants to go down to the shop or he wants to walk around. So you cannot take this tube everywhere and go. So the patient will have something called as a bib. It's like how children have bib if something falls, you know. So in order to keep it clean. So it's this is called a bib. So it is air, oxygen passes through this. Okay, as you see, it is quite transparent. Okay, oxygen passes through it, and it still causes humidified air to pass through. Okay, so this tube, this bib can be washed and it can be reused, and this is what we tell patients. And then there's another thing called as HME. So you can see this green thing here. So this is again what just fits onto the trachea tube like this. Okay, just fits onto the trachea tube, and it has an additional feature where you can give oxygen also. Okay, if you don't need to give oxygen, that's fine. The patient just wears this and he can stay with it. Okay, so it is discarded. You cannot reuse it once it is dirty. So are you guys clear? Are you following? Just give me a thumbs up. Yes? Okay. Okay.
I think they look like they are following.
Okay, that's good. That's good because I don't want to just go
No,
on.
it's all muted, so that's the reason,
No problem,
So
no problem.
just
That's
to
fine.
avoid the interruption in the middle. Yeah.
Yes, yes, yes. Okay, shall we carry on?
Yeah.
Okay. Okay. The next part is your suction. Okay, so suctioning is in simple. I know they have different definitions. So I would just say that removal of secretions, okay, pulmonary secretions is suctioning. So you need a suction catheter. So the thing is now, How do I know what size catheter to use? Okay, so there is a little formula that we use here. Okay, so I'll tell you even more shortcut formula. So if the size of the tube is 8, so you just add plus 4. Okay, whatever is the size of the tube, tracheotube, you just add plus 4. So how much is it?
Wow.
12. Okay, so you pick up that size 12. You pick up the size 12 suction catheter. So it's important that you have the right diameter of the suction catheter. So suctioning, you all know it's a sterile procedure. So you use your sterile gloves. So especially now with COVID, I'm sure that you are all very familiar with your PPE. Okay, so you use your apron, gloves, fluid shield mask, okay, catheters, sterile gloves. So these are the equipment that you need. And when you suction, you just go pen size. Okay, the size of a pen. Don't go too much. Don't go. Just you have markings here. I would just go about 9 to 10. Okay, have that in. Okay, and then in ICU you usually pre-oxygenate the patient and you give. So you put it in. Okay, and then using your negative suction pressure, you just bring it out. So this inserting this catheters should not be more than 15 seconds. Don't leave it in for a long time. Okay, it should just be a quick thing. Okay, so you can just go in and out. So that is your suction. I'm sure you all know it, you just need to practice it. Okay, so the next part is communication. As I told you, it's very difficult for patients with a tracheostomy tube to communicate, and you have different devices now. Okay, so usually patients are frustrated that they cannot speak, and especially if they cannot read and write, it is even more difficult. We can see the frustration that they cannot able to tell us what they need. But there are some devices that have come into the market that help us help the patients to speak. So these are called as speaking valves. Okay, so it's a lot. I can't be explaining everything, but I'm just giving you a gist of it. So it's called. You can have a look at it. It's called a Passenger speaking valve or a PMV. So these kind of devices are used on fenestrated tubes. Okay, or you can use it on a non-fenestrated tube as well. So what happens is when the tube is still in place, these little things are just placed above, okay, on the cannula. Okay, it's just placed above. So when the patient is has this tube and he wants to speak, it's a one-way valve. Okay, so he's able to automatically take in air, and when he wants to it opens only once. Okay, so the air just flows inside, and when he wants to say something, the air is directed back through his vocal cords and he's able to make some speech. Okay, so it's a lot, so it will need a different session on its own. But just to tell you that there are devices that are available for the patient to speak. So the only thing is, do not use these tubes, do not use the speaking valve when the cuff, if your cuff is inflated. If the cuff, if this cuff is inflated and you're using the speaking valve, the patient is going to choke and die. So be very careful that if ever you're going to use a speaking valve, that the cuff is deflated. So that's the thing. So these are reusable ones. You just wash them and you can put it on. So usually we use it on patients who are able to understand. Even if they are choking or anything, they should be able to take it out. Okay. So do not use it at night or when the patient is asleep. Okay. So you can wash it and use it again. Okay. So this is Passenger valve. So you can make a note of it and read about it if you want. Excuse me. Okay. Okay, coming to the next thing, mm, an overbed sign, which is very important. Okay, what it this is an overbed sign. It will tell you what kind of tracheostomy the patient has had. Okay, whether it's a percutaneous or a surgical, and behind it, you can see this, and behind it is an algorithm. That means what to do if there's an emergency. Just a second.
I think he has gone on mute, Suresh.
Okay.
Yes. Sorry about that. Okay, so it's just that every patient should have a little bed sign, okay, which tells them what, whether it's a tracheostomy or a laryngectomy, and then you have the algorithm which we will go through in the next few minutes. Okay, so all this is nice, it's all good, the tube is in place, everything is good, but the actual problem starts when there is an emergency situation. So today I want to just tell you like what you need to do if there is a problem. Okay, so usually there are different types of problems that you and me working on a busy ENT or a surgical ward will have. Accidental decannulation. So if the tube falls out, what are you going to do? Are you going to run away from there? Yeah. So I would have ran away if I was a student. I would be like, oh, I don't know what to do, but unfortunately or fortunately, I have to face it. Okay,
You
so
might be scared.
you might be scared.
Yes.
Definitely, it's a very very scary time when the patient is going all blue and he's like breathing that way, and you don't know what to do. So you are also breathing the same way. So everyone is in a panic. Okay, so there are different scenarios which can put you into a panic like that. But today we want to just break that fear, and we should know exactly what to do. Okay, so I'll be going through these things. Okay, so here is your friend. If there is an accidental decannulation, I was talking to you about the emergency trachea tray. So bedside tray. So every patient should have a spare trachea tube. It's not that the tube falls out that time you are going and searching in the ward and then it's not there, then you're going to the neighbor ward. No, 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 don't. That is the common scenario, and then that nurse won't give you. She said you took last time, you didn't give me back. So this is this is, we have all gone through it. Yes. Okay, and then and you're here and you want to just run home and not come back. So we don't want that kind of a situation. So it's important that you set up your bed space. Okay, so you have your trachea tray bedside, and then so we recommend that even if the trachea tube falls out, yes, immediately call for help, which we know how to do. Call for help. Okay, so what you as a nurse there, you can be a hero here. Okay, by not running away, but by staying with the patient and telling the patient and reassuring the patient, and you can use this trachea. Okay, so you can use the trachea and you can open and keep the space, keep the trachea stoma open. So you have this here. So you use it in north south position. Okay, you keep the stoma open. So till your friend or your colleague goes and gets help, you can be there and do this. Nothing is going to happen. All you need to do is keep this open and apply some oxygen. All you need is oxygen. Okay, so accidental decannulation from next time, you all will be heroes at it. Okay, so administer oxygen. Okay, so I would recommend that you give oxygen from the face, that's the nose and mouth, and also through the stoma. So you don't know which is working, so you just give that, and you can have the next size tube ready or a size smaller. Usually we tell us have a size smaller because if the stoma has closed off, it's easier to put in the size smaller. Okay, so who would you call? Here it depends now. We usually call the anesthetic on call because some people think that they need to call me. So they will ring me, but I'll be somewhere else. It will take me 10-15 minutes, or they'll think I should ring the consultant of this patient because he is taking care of this patient. No, it's not. Consultant is busy somewhere else. So you call the anesthetic on call. Okay, anesthetist on call. He is available and they will be the ones who are in the hospital 24 bar 7. So they can come in and they can do the put in a tube. Put in a tube. But if you are competent, you can put in the tube, which will need some training. As I told you about this stay suture, so you pull that stay suture this way, and the hole is opened, so the tube can just go in straight away. Okay. So the next most common problem is tube occlusion. Okay, so if the patient is having lots of secretions and you haven't checked the patient, you saw the patient at 8 a.m. when you started, and now it is 12, you haven't seen the patient in that 4 hours, there are loads of things that can happen. Okay, the tube can be occluded, okay, with secretions or anything, and here the patient, you are going to check the saturation is showing 80%, and now you are all scared, you're panicked, what to do. Okay, so the first thing, that's why you have an inner cannula. So your first thing is assess the patient, you check the inner cannula. Okay, and if it is blocked, okay, if it is blocked, you take it out, throw it, put a fresh one. If it is not, okay, and still the patient saturation is 80%, it's not coming up, then you suction the patient. Okay, you suction the patient, and you see, when you suction the patient, you can see resistance. That means it is hitting something, it's not going in properly. Okay, that means the patient, there is some problem. Okay, there is some problem. If the suction catheter you're not able to pass, there is some problem. That means the I won't tell you more in detail, but it means that if it looks nice and neat from here, if it looks nice and neat from here, and if you cannot pass the suction catheter, it means it's sitting in the false passage. False passage. So it's outside nice like this. You think everything is fine, but it is sitting somewhere here. Okay, so when you suction, it's hitting resistance. So in that case, here we just tell them if it is sitting in the wrong place, you take out the tube. But you follow your local policy and you can find out what they do, because even few minutes, few seconds is important. Patient can have a hypoxic brain injury if the oxygen is not delivered to the system. So we tell that you take out the trachea tube, and again you go back to your previous method of keeping the stoma open until you get help. All right.
ಕೆಳಗಡೆ ಯಾರು ನೋಡ್ತಾರೆ?
The third one is your cardiac arrest situation. I'm sure nobody wants to be in this situation, but unfortunately, some of us have to be in that kind of situation. So, unconscious patient, you have gone, knocked the door, seen that the patient is not responding, has a trachea tube in. So, it's a very scary thing. Okay. So, you start off your BLS straight away. Okay. 30 compressions, 2 breaths. So now the problem is you can't give, how are you going to give oxygen? How are you going to give oxygen? If the patient has, it's not like your normal, it has a different airway. So how are you going to give oxygen? So there is something called as catheter mount. Okay, cap mount. They use this thing in ICU. Okay, and every emergency trolley will have a catheter mount. Okay, cap mount. So what you do is this, the tube is in here, so this part fits in here. Okay, and this part is connected to your ambu, and then you can give oxygen. So remember these things. Okay, this is called a catheter mount. Okay, so that's your arrest situation.
ರಿಫ್ರೆಶಿಂಗ್.
Okay, so
25
that's how
ವರ್ಷ
you do.
ಮುಂಚೆ
Use it.
ನಾನು ಐ ಸಿ ಯು ಮಾಡ್ಬೇಕಾದ್ರೆ ಇದು
You
ಕೇರ್
can
ಮಾಡ್ತಾ
give
ಇದ್ದೆ.
ambu, attach to
ಟ್ರೆಕಿಯಾಸ್ಟಮಿ.
15 liters, and then you follow the same thing. Make sure you see your chest twice. Okay, that's fine. The next thing, those are the three emergencies. Now, Mr. X or Mr. Y has had tracheostomy. His surgery is over. Now he no more needs the trachea tube. So we call removal of the trachea tube as decannulation. Okay, so when we remove the trachea tube, it looks like this. So it takes about
Scary.
7 to 10 days or 7 to 14 days. It depends from patient to patient for it to heal up. Sorry. So you put an airtight pressure dressing, and it is inspected every day or 2 days to see that it is clear. Okay. So in this, then the patient is back talking, back swallowing, and doing things as normal. Okay, so that's about your tracheostomy. Little bit about laryngectomy, I will tell you, not much in detail. Here, what you need to remember is a larynx is complete removal of larynx is laryngectomy. So here there is no connection between upper airway and and your lower airway here. Okay, so you cannot intubate the patient. So we have had patients, like there have been researches where a neck breather. Okay, this is a neck breather. That means the nose and all that is still there. You can physically see, but there is no connection. Internally, there is no connection between nose mouth. So even if you put the tube, it's only going to hit the esophagus, but it's not going to go. You're going to intubate the stomach, but you're not going anywhere into the lungs. So this is something that you need to know. I personally have not seen any laryngectomy while I was back in India. But now, as I've seen some researchers, there are laryngectomies in India. So you will see, you, I don't know if you have already seen, but you will see. So always you remember that they have the right bed sign. Okay, laryngectomy. It should just flash like this, that they are neck breathers and there is no connection between nose, mouth, and the lungs. There is no connection. Okay, so the opening just starts from here. So anything you need to do, give oxygen, you have to give oxygen through the stoma. Okay, so these things are called as Larry tubes. Okay, they are flexible tubes. Okay, so these tubes are put into the stoma. So patients with laryngectomies can speak. You see that that's a speaking valve. Okay, for a tracheostomy, we saw a different speaking valve, but for a laryngectomy, this is it's called a TEP, speech and language to it. We don't have much to do with it. So you just need to know that. So they put their finger on that little hole there and they try and speak. Okay, so this is a laryngectomy. So your care, now you have a patient with laryngectomy, so you can take out the tube here. Okay, don't be afraid to take out the tube because it's a permanent stoma and it's an end stoma. So even if you take out the tube, no problem. Okay, so that's why you see that the stoma is open. Okay, so you use something called as Philly's forceps. Philly's forceps. Okay, so you give the patient a mirror and you ask the patient to inspect their stoma, and if there is any dried secretion, you just use these forceps and you take out the secretion. Because the most common problem here would be patient would have dried the secretion, and that can be a cause for cardiopulmonary arrest.
Means voice
Okay,
ಹೋಗ್ಬಿಡ್ತದೆ.
this can happen. So that's why it is very important that the patient has some kind of humidification. Again, same principles like tracheostomy. Again, to have some kind of humidification. Okay. So as I showed you, the pink thing. So it has an algorithm behind what to do in an emergency. Okay, the same steps here. So so what you do is you can put in a trachea tube. Anyone can put in a trachea tube in the laryngectomy stoma. Okay, and then you connect your catheter mount and you can give oxygen. Okay, uh, that is the only difference. But you can't intubate. You tell the anesthetist, sir, this is a laryngectomy. You cannot intubate. You just have to give oxygen through this. So even if you are giving oxygen, you give it through this, through the stoma. Okay, that's your laryngectomy emergencies. Okay, so the last thing, can you spot the difference? Now this is open. I think you can unmute them. You can spot the difference and tell me which is a laryngectomy and which is a tracheostomy. Can you tell me the difference?
The options is open, so you can unmute yourself to answer it, please. Okay, we can move on, Lydia.
I think that's it, sir.
Yeah.
We have come to an end of the presentation. So this is a question.
Is that the right one? Is that the right one? Tracheostomy, and the left one is laryngectomy.
We'll let the students answer.
Well, there's no one trying, so
No one trying?
No, they can put on they can put the answer on chat box.
Yes.
At least we can
Nobody-
give you some time. Yeah.
Okay. Anyone else has got questions in the meantime? Okay. We can stop sharing the screen, Lydia. Let's go to the
Okay, okay.
Thank you.
Okay, so
Lydia, it was an excellent presentation. Anyone has any questions?
Yes.
Yes, go ahead.
How many hours we should inflate and deflate the tracheostomy tube cuff?
so
How often?
how often?
How often?
Okay.
Yeah.
So if the cuff, we don't inflate and deflate the cuff all the time. So if the patient, now it's again different. If the patient is in ICU and they are using the speaking valve, then the cuff is deflated. That means the patient is not on ventilator. Okay. So that time you can deflate the cuff. And again, if the patient is back on the ventilator, sometimes patients have ventilator for 12 hours, 13 hours, and other times they are just on oxygen, on airway. So that time you deflate the cuff. But for normal patients on the ward, so we deflate the cuff, we leave it deflated. If they are vomiting, for example, and you notice that the patient is vomiting and you suction and you are finding feed in the suction, that's when you inflate the cuff. Okay? But if cuff inflation means patient is still not doing good. If cuff is deflated means he is progressing. Is that okay?
Okay.
Can I also give you another tip? Correct me if I'm wrong,
Yes.
Lydia.
Yes.
If the patient's level of consciousness is less than 8,
Yes.
then and if the cuff is deflated, then you must make sure that the cuff is inflated just to protect the airway.
Yes, definitely, because the patient does not have a swallow reflex. So it is important that you check the cuff pressure or the cuff, even if you touch it, you know if the cuff is inflated or deflated.
Yeah.
Yes.
Okay. If you don't have a questions, I will have questions for the audience.
Swami, 1 minute. I have one question from the YouTube.
Yeah.
Tarun Sebi, how to disinfect inner cannula?
Okay. So now what we are following European guidelines here, which say, again, it depends from company to company. Here we are saying that we dispose, they are called disposable inner cannula. That means if you see it is dirty, you are going to throw it out and put a fresh one in. But I'm not very sure what the local policies say, but we usually say to discard the tube, throw it away.
And am I right in saying that we need to take out inner cannula while we're suctioning?
Not necessarily. You leave the inner cannula in and you suction. You don't need to take out the inner cannula because we measure the suction catheter will still pass in through the inner cannula.
Okay. My next question is, okay, this is for the audience because you're not asking questions. I might as well ask you the questions because you seem to know it already. So when you got a patient with this tracheostomy and you've been asked to suction this patient, how long will you suction this patient for? This is the audience question for the audience. I guess some of you have looked after patients with tracheostomy, right? I'm sure the Davangere team are nodding their head.
5 to 10 seconds. 5 to 10 seconds. More than 15 seconds, we should not suction the patient.
Brilliant answer. Brilliant answer. Yes. Yes. Good. And I guess you are all using humidified oxygen, right? In Davangere.
Yes.
Do you look after tracheostomy patients in the ward settings or ITU settings? Only in ICU. Okay. If do we need an ICU bed for a patient with a tracheostomy? Yes or no? Is ICU an indication for a patient with tracheostomy?
I say no.
Yes. Yes. But then it comes to the competencies. Whether you have a competent nurse who can look after the patient in the ward environment. Sorry, Lydia, I've taken over.
No,
I have to acknowledge here, Swami, for that one, taking care of the patient in the tracheostomy or who are all coming out of the tracheostomy in the ward settings. So, Lydia, anyway, this was very nice session. So I must say that it was refreshing me. So now I'm a psychiatric nurse working here in UK over the last 18 years. But I'm now going back to 25 years ago when I was working in Manipal Hospital. So I have I did work on the ICU, work with the tracheostomy patient as well. And, it is really refreshing for me. I must acknowledge that when I was in the ward in Manipal Hospital, that time, the patient who had a tracheostomy, they suddenly become breathless, not able to breathe. Patient was in the non-oxygen room. There was no central oxygen. So patient needed emergency oxygen to connect. So what I have to do, I was in the 9th floor. So I can't wait for others to attend or bring the oxygen trolley, whatever it is. So to be honest, I became a hero in that day. So what I did, I lift the patient in my both hand and moved to the other area where the central oxygen was supplied.
Okay.
So that was the interesting thing for me to share with you. That is the one thing how we manage the tracheostomy patient who required the oxygen level. Still I'm remembering that things. Anyway, thank you very much for recalling
Thank you,
things.
sir, for sharing that. This every situation and every scenario is very different. So you cannot predict what the patient's outcome would be. But if you have these things in place, if you have your trachea tray, if you have your oxygen working bedside. See, sometimes now, so we have started here now. Some patients go to different hospitals or they go for radiotherapy to a different setting. So transporting this patient becomes difficult. So a nurse cannot travel and with the patient to another hospital just for the sake of radiotherapy. because of nursing shortage. So we have started training healthcare assistants who are just competent in taking care of these patients. So what happens? So they have an emergency, they have suction catheters, they have suction equipment, but still it's quite a challenging job. Not everyone will be able to do it. It will just take a lot of practice, and it needs your guts. It really needs your guts.
Exactly.
So, but if you know what steps to follow, what exactly to do. So I encounter patients, so my bleep just goes off, it just goes off. They ring me, they say, I have a patient here. So I just have to be there in a second. Sometimes I don't have things. So using the best thing, whatever is available there, using your common sense, just assessing your environment, you see what best you can do. And that's how you need to save your patient. So I must say, well done, sir, for what you did 25 years ago.
Thank
Uh,
you. Um,
yes.
The
I think
other things to remember in the ward settings is especially because the staffing ratio is really so poor. I mean, whether it's in India or UK, the same setting, it's almost similar. That if you don't have competent staffing levels within your clinical area, I think you should decline admissions with tracheostomy. That's one of the criteria. If you don't have a trained staff to look after patients in the ward environment, it is unsafe for the patient and is also unsafe, not fair on the staff. If you don't have the adequate training, so that's where the competencies comes in. That's where the training issues comes in. So you must always resist taking a patient if you haven't looked after a patient with tracheostomy. That's one thing.
Yes, you should be able to say, like, I need training, and till we get the training, let the patient stay in another ward, and then we can receive the patient. So this part, I think, becomes a little difficult in our settings to say no. But I think it's better to say that you don't know than to risk yourself and the patient's life.
Absolutely.
So
Yeah,
there are refresher courses for those of you who have forgotten. Okay, for example, like if I'm not doing this for 5 6 years, I will forget it. So there are refresher courses. You can get yourself trained with that.
Yeah.
And yeah.
Okay, the other thing is if you have a patient with tracheostomy and you do have competencies, but you have this patient, like Lydia said, in an acute condition, you need to have a close monitoring just in case if they pull out the tube, where you need almost at a 1:1 level care, or under those circumstances, you need to make sure you place the patient in a location where there is constant supervision, perhaps close to the nurse station where there is someone all the time. And the second thing is you must have a tracheostomy backup kit, like Lydia mentioned. And the person who's nominated to look after this patient should be aware of all the equipment and make sure they check it at each shift when they take a handover. You must make sure when you take a handover, you go through the tracheostomy kit, emergency kit, and make sure all the equipment is there. That could be misplaced easily. So these are all practical tips that I have learned when I look after patients with tracheostomy in respiratory wards. And you must always make sure that the staffing level is adequate for the next 24 hours each shift. When you come in, make sure you've got enough staffing. You are trained, not just adequate staffing, you are trained to look after a patient with tracheostomy. Humidified oxygen is another thing. I know some of the hospitals still don't have centralized oxygen supplies, so you must make sure you have the humidified oxygen supplies. And then the emergency contact details for anesthetists. Not everyone has the same bleep system or the pager system that you have we have in UK. You have different arrangements in India, I understand that. How does it work in Davangere or anybody else for that matter? Anybody can unmute and say, how do you contact anesthetist, or who do you contact in the emergency?
9 number, sir.
9 number, yes.
9 number.
Yeah.
9 is
local telephone.
9 is your switchboard, right?
Switchboard.
Yeah.
9 switchboard ಫೋನ್ ಮಾಡಿ ಅವ್ರು ಫೋನ್ ಎತ್ತಿ
ನಾವು 9 ನಂಬರಿಗೆ ಕಾಲ್ ಮಾಡಿದಾಗ ಸರ್ ಅವರು ಅನಸ್ಥೆಟಿಸ್ಟ್ಗೆ ಕನೆಕ್ಟ್ ಮಾಡ್ತಾರೆ. ಇಮಿಡಿಯೇಟ್ಲಿ ದೇ ವಿಲ್ ಕಮ್ ಹಿಯರ್.
Okay, my question is 9 an emergency?
Yeah.
So if you want to make an outside call, what will you dial?
9.
Sister, you want to call?
ಹಿಯರ್ ಇಲ್ಲಿ ಹಾಸ್ಪಿಟಲ್ ಏನಾದ್ರೂ ಎಮರ್ಜೆನ್ಸಿ ಇದ್ರೆ ಸರ್ 9 ನಂಬರ್ಗೆ ನಾವು ಕನೆಕ್ಷನ್ ತಗೊಳ್ತೇವೆ, ಕಾಲ್ ಮಾಡ್ತೇವೆ. ಔಟ್ಸೈಡ್ ಇಂದ ನೋ ಐಡಿಯಾ.
ಅಲ್ಲ ಸಿಸ್ಟರ್, see, there is a what I'm trying to differentiate is in an emergency there should be a fast track way of dialing for somebody. Okay, ಈಗ ತಡೀರಿ, ನಿಮ್ ಸೂಪರ್ವೈಸರ್ ಕಳೆದೋಗಿದ್ದಾರೆ, ನಿಮ್ ಸೂಪರ್ವೈಸರ್ ಕಾಂಟ್ಯಾಕ್ಟ್ ಮಾಡ್ಬೇಕಂದ್ರೂ 9 ಮಾಡ್ತೀರಾ ಅವ್ರ ಮೊಬೈಲ್ ಮಾಡ್ಬೇಕಂದ್ರೆ, ಹೌದಾ? ಇಲ್ಲಿ you don't have that amount of time. Every second is important. You need to make sure that you get some help within 5 minutes. So you dial the switchboard at 9, then somebody picks up, they take their own time. How will they differentiate that yours is emergency?
ಆನ್ ಡ್ಯೂಟಿ ಕಾಲ್
What I'm trying to, sister,
ಐಸಿಯಲ್ಲಿ ಯಾವಾಗ್ಲೂ ಆನ್ ಡ್ಯೂಟಿ ಅವ್ರು ಇರ್ತಾರಲ್ಲ ಸರ್.
ಅಲ್ಲ ಐಸಿಯುನಾಗ ಇರ್ತಾರೆ ಸಿಸ್ಟರ್. ಈಗ ವಾರ್ಡಲ್ಲಿ ಕಳಿಸಿದಿರ ಪೇಷಂಟ್, ಈಗ ಕೋವಿಡ್ ಎಲ್ಲ ಕಡೆ ಕೋವಿಡ್ ಇದೆ, ಈಗ there is COVID everywhere, right? So if the ICU is full of COVID patients, they will push the tracheostomy patient to the ward. So how will you look after the deal with the emergency?
ನಮ್ಮ ಮೊಬೈಲ್ ಇಂದ ಮಾಡ್ತಾರೆ ಸರ್.
There you go. That's it. And somebody is chatting to somebody on WhatsApp, or somebody is dialing somebody, and you get another call. So this is not the right way. That's what I'm trying to say. Essentially, you should be able to differentiate what is emergency and what is non-emergency. So that is the system that they have to introduce.
Okay.
I mean, that is something for you to consider about change in practices in your clinical setting. For example, what we do is in UK we dial 2222. 2222 is a universal number. Across UK, anywhere you dial, any hospital internal phones, you call 2222. It's an emergency. Any hospital you go, 2222 is an emergency. Outside the hospital settings, it's 999 or 91. Anywhere you call, you get emergency help. So likewise, each hospital should have some emergency contact numbers. So if you dial that, even the switchboard should realize that it's an emergency number. They have to prioritize your calls. Okay, any other questions from the audience? Thank you so much, Lydia. It was a lovely presentation. It was quite refreshing. Even after 10 years, I'm glad I've had some memories left in my brain still. But thank you. It was such a lovely presentation. I hope the audience enjoyed it too. So,
yes, it can be. If you are not using, if you are not in this area of tracheostomy, it can be like, I don't know anything, or why should I know? But you never know now how things are changing with COVID. We have had so many patients with tracheostomy now. So, and ICU beds are limited, so they'll be obviously pushed to the ward, and you will be made to take care of them overnight. So it's just so that's how the times are now. So it's very important that you just get to learn, and you can always contact me if you want to know anything more. Yes, so I still want to come back to my last thing, on the screen, to spot the difference. Can anyone spot the difference?
I think only Swami is the one spot the difference, I believe.
I don't know whether it was right or wrong.
Can anyone still spot the difference?
You have to share
ಯಾವುದು tracheostomy, ಯಾವುದು laryngectomy?
ಅಲ್ಲ, ಅದು ಸ್ಕ್ರೀನ್ ಶೇರ್ ಮಾಡ್ತೀರಾ ಒಂದ್ಸರಿ? ಇಫ್ ಯು ಹ್ಯಾವ್
ಮಾಡಿದ್ದೀನಲ್ಲ, ಇಲ್ವಾ?
ಇಲ್ಲ, ಬಂದಿಲ್ಲ. Yeah, is here now.
Yes, I just want to know if you can tell me what is a tracheostomy and what is a laryngectomy. Can you tell me?
First one tracheostomy, second one laryngectomy. First laryngectomy tube will be flexible tube, sir.
Okay. Anybody else?
I think I am with the same. The first one is tracheostomy.
Okay, that's good. Anyone else? It's a free. I'm not charging you. You can tell me. You can just give it a guess and see.
So you are saying, okay, I'll go the opposite. I say right one is tracheostomy, I think, and the left is laryngectomy.
What do the students want to say?
Looks like there's no students left. They're all gone.
They're all gone. It's not an emergency. You don't have to run away. Okay, let me just tell you, you cannot know the difference. As I told you, behind the dressing, you don't know what kind of stoma it is. You will never be able to know whether it's a tracheostomy or a laryngectomy, because even in a laryngectomy patient, you can put a trachea tube. So if they both look similar, the only way you can know the difference is with your bed signs. Okay, so it's just very important that you have. See, you can download this from. I have downloaded it from tracheostomy.org.uk, and you can make it, for your own hospital. But this is the only way that we will know if the tube is in place. We cannot differentiate unless you have the bed signs. So it was a good try, I must say. Well done, all of you, and thank you very much.
Lydia, can you share that link for me? The website link.
Sure,
so I can
sure.
share it in
Sure,
the
I can. I will send the link. I should have put it on my slide, but
Right.
I'll send it to you.
Oh,
Thank you.
yeah, once again, thank you very much, Lydia, for your time to be with us for more than 1 hour now already. So, good audience. Thank you very much, audience, as well, especially SS hospitals. Always they are very cooperative with us.
Thank
You
you.
know, we're trying to, support them with their clinical knowledge. I hope they are somewhat they are taking our some of the advice or the suggestion, information. So thank you very much once again. And our next session is on the 1st of May, which is the same time. It will be non-invasive ventilation. Am I right, Swami?
Yes, I think like today, the next one is another airway session. Next one, it's about non-invasive ventilation, especially COVID time. It's probably going to be precious one as well. We're talking about the BiPAP and CPAP and as well as oxygenation.
Yeah.
So please do make sure that all of you participate and convey the message to your colleagues as well. We'll be sharing the link soon.
Yeah, it's just getting the knowledge or information. You don't have to be in that particular area. You don't have to be working in that specific area. I'm a psychiatric nurse anyway, but still I'm very very much interested. Refreshing other thing as well. So the same thing I would suggest everyone to join for our next session. Once again, thank you all. Thank you very much. Thank you, Swami. Thank you, Lydia.
Thank you. I just want to take this time to, I can see my teachers from SDM, so I want to just take this time to say thank you to all of you for joining in, sir and madam, and thank you so much. And
Thank you.
Thank you, dear audience. You have been wonderful, and thank you, Swami sir and Suresh sir, for giving me this opportunity to
who is your
share
teacher?
a little bit.
Who is your teacher from SS Hospital?
I think I can see David sir, and I can see Manijeshri madam and Nagesh sir. They're all my teachers from SDM.
Oh, that's very nice. I'm
So
definitely
I'm very, very privileged.
I'm definitely there. Appreciate you. I'm sure.
Thank you, sir. Thank you so much.
Okay, thank you, everyone.
Thank you.
Thank you.
Thank you.
See you in your next session. Thank you.
Thank you.
Thank you.